Connective tissue disorders, module 4, lecture 7 in the genetic series. Connective tissue has many components. It is important in holding tissues together. It holds our bones together, it holds our joints together, and most importantly, it holds major vessels in the heart together. Abnormalities in any of the components of connective tissue can result in weakness of the tissue. Collagen is one of the most important components to connective tissue. There are over 25 different genes that code for various forms of collagen, and some are more important in bones, while others are more important in joints. Many of the collagen genes start with the letter COL. So there's COL 1A1 and 1A2 that's important in bones. There's COL 5A1 that's important in connective tissue. So if you see the word COL, it probably has to do with some type of connective tissue. As stated, collagen is important in tissue strength and bones, joints, as well as the vascular system. In addition to collagen, there are also a number of other genes that work with it. Abnormalities in any of these proteins can result in weakness in the tissue. And so the collagen gene will make a protein, and usually there's two proteins that get together and it makes kind of a rope, and this gives tensile strength. Classic disorders of connective tissue include osteogenesis imperfecta, which affects bones, Marfan syndrome, Loeys-Dietz, that's more in connective tissue. There were two guys named Ehlers and Danlos that named a bunch of things that have little to do with each other. But there's Ehlers-Danlos type 1, which is a classic form, and Ehlers-Danlos type 4, which is a vascular form. So osteogenesis imperfecta type 1 is characterized by fractures. It's really weak bone. You can almost see there's very little mineralization of the bone. Blue sclera, the sclera, the white parts of the eyes, and because you can see to the back, they appear blue. Hearing loss, there's over 100 bones in our ears, so any weakness can result in hearing loss. And short stature for genetic height. So this is osteogenesis imperfecta. It's inherited as dominant. It occurs in about 1 in 20,000 liveborns. There are many different forms. Most common, as stated, is type 1. It's characterized by short stature. Fractures, usually once a child becomes ambulatory, they will fracture tripping over a table, jumping off a swing set, just basic childhood things. Blue sclera, but they have normal life expectancy. Type 2 is a perinatal lethal. There are fractures prenatally. So in a water bath, they're fracturing. The recurrence risk is about 5 to 6%. This is usually de novo. But what often happens is one of the parents carries it in some of their genes in rare cases. And then it will be 50%. Type 3 is short stature, significant short stature, limb bowing, and fractures. And then type 4, there's normal sclera, fractures. It's kind of in between 1 and 3. So what happens with osteogenesis imperfecta is normally we have collagen 1A1 and collagen 1A2, and we have 2 copies of collagen 1A1 to 1 copy of collagen 1A2, and they get together and make a nice tensile rope. With mild OI, there's a stop codon for one of the copies of the collagen, in this case 1A1. So when we make normal collagen from the other copy, we only have half the amount that we need. And it gets together. The good news, though, that's the bad news. The good news is when they get together, they make a normal tensile strength rope. During childhood, you're growing rapidly, so the bones are thinner than they should be. They don't have enough collagen, so there's a number of fractures. Usually in late adolescence to early adulthood, these fractures cease. However, these bones are weaker than they should be, and so osteoporosis usually occurs in the 40s. That's something that I think that's probably under-recognized. But so the typical history of this is multiple fractures, sometimes 15 to 20 during childhood. They stop during late adolescence. There's a honeymoon period between 20 and 40, and then, early hip problems, joint problems, and other kinds of issues as they get into the late 40s, early 50s. Then there's severe form of OI, and this is the type 2 and the type 3. And what happens is the change in the gene is not so severe that you make no protein. So in a certain sense, you're better off with nothing than you are with something abnormal. But this abnormal protein does not fold well together with the other chains, and so this rope, instead of having good tensile strength, kind of falls apart. The next disorder we're going to talk about is Marfan syndrome. And the GENET criteria with Marfan syndrome, there's actually 4 components to the diagnosis of Marfan syndrome: systemic features, or outward features, ophthalmologic features, cardiovascular, and then molecular. So systemic features include a chest wall deformity. Here we have a pectus excavatum. You actually get a point for that. If it's an outgoing chest, it's called a pectus carinatum, or pigeon chest, you get 2 points. Scoliosis greater than 20 degrees, you get 2 points. Flat feet, you get a point. Being able to do both of these components. This is a Steinberg thumb sign. You can fold over your thumb and it comes out the end. And here's a wrist sign. When you put your thumb and your pinky finger around your wrist, there's overlap. You get 3 points if you can do both. You get 1 point if you can do one or the other. Other features include the lower body greater than the upper, or the wingspan greater than the height. Stretch marks, especially during adolescence. Myopia, difficulty seeing in a distance. Mitral valve prolapse. These, while they're ophthalmologic components, have been moved into the systemic features, because if we worried about everybody with myopia and mitral valve prolapse, we'd basically worry about everybody. But when you put this all together, if this is more than 7 points, that's a sign of systemic features for Marfan syndrome. Ophthalmologic ectopia lentis. In Marfan syndrome, the lens goes up. In the metabolic, we talked about in homocystinuria, it goes down. So this is a board-like question that the lens is upward. Some people think Marfans are tall, so the lens goes up. Myopia, again, is a systemic feature. And another thing an ophthalmologist may notice is a flattened cornea, as well as an elongated globe. Cardiovascular, it's not a big deal to be tall and flexible. It makes you a great athlete. The problem with Marfan syndrome is that because the connective tissue is not working correctly, there's dilatation of the ascending aorta. This can result in aortic dissection. And they also have mitral valve prolapse. And again, that's because of the weak connective tissue and the valve is prolapsing. So Marfan syndrome is caused by a mutation in the gene fibrillin, or FBN1. This is located on chromosome 15. Pathogenic mutations of the fibrillin mutation are identified in 97% of patients that fulfill the clinical diagnosis for Marfan syndrome. And fibrillin is important in elasticity, so the connective tissue is not elastic enough. So, for instance, in the heart, when it expands as the blood's coming out, so it's not expanding and going back normally, and so it rips. And that's what a dissection is. So, new GENET criteria. If there's no family history of Marfan syndrome, so we take a 3-generation family history, and there's no family history of either Marfan syndrome or suspected Marfan syndrome, you need an enlarged aortic root and a dislocated lens and an enlarged aortic root, and the Z-score is a measurement of how enlarged the root is, or fibrillin mutation, an enlarged aortic root, and 7 points of systemic features, or ectopia lentis and a fibrillin mutation. So this is, so when there is no family history, you need 2 components to make that diagnosis. And 3 of these you might see have to do with the heart. So whenever you're evaluating a patient for Marfan syndrome, you need to have an echocardiogram to make that diagnosis. In the present, so if a child came in and one of their parents was diagnosed with Marfan syndrome, you only need one of the following: a dislocated lens. So if I did an exam on a 8-year-old whose mother had Marfan's and they had 7 or plus points, they'd technically have Marfan syndrome. An aortic root with a Z-score over 2 over 20 and over 3 under 20, and then the familial fibrillin mutation. So if I had a newborn who one of the parents had Marfan's and I did genetic testing and they had the fibrillin mutation, they would have Marfan, even though they were too young to complete the physical exam. Loeys-Dietz makes Marfan's look like, oh, yay, it's only Marfan syndrome. It's a much more frightening disorder. It wasn't even described till 2005. It's caused by different genes that interact with fibrillin, TGFBR1, TGFBR2, and something called SMAD3. There's no difference in the phenotype depending on which of these three genes is changed. Compared to Marfan's, they have an earlier aortic dissection, and sometimes it can go from a normal aortic root to dissection within the year. Whereas Marfan's, usually it's a more slow process. Patients look very similar to Marfan syndrome, including a pectus deformity. The aortic root dilatation and dissection, as I stated, could go very rapidly. And the other concern about Loeys-Dietz is their arteries are very tortuous throughout the vascular tree, which actually puts them at risk for stroke, as well as aortic dissection. So here's some of the clinical features. And again, here you can see this positive Steinberg thumb sign. They can have a bifid uvula or sometimes even a cleft palate. They're at risk of cerebral, thoracic, abdominal aortic aneurysms and or dissections. So physical features, hypertelorism, which is wide-spaced eyes, a pectus deformity, a scoliosis, again very similar to Marfan's, joint laxity, arachnodactyly, which is long fingers, bifid uvula, cleft palate, and thin translucent skin. So features very, very similar to Marfan's. And there's also a risk of rupture during pregnancy. So even compared to Marfan's, this is a much more risky pregnancy. As I was stating, Ehlers-Danlos is a family of disorders that's characterized by joint hypermobility, easy bruising, and elasticity. The reason that they bruise easily is because the connective tissue doesn't hold together well, so any kind of bleeding underneath the skin, that's what a bruise actually is. The symptoms derive their name from reports of Edward Ehlers, a Danish dermatologist in 1901, and Henry Danlos, a French physician with expertise in chemistry of the skin in 1908. So they were actually separate descriptions, and that's why they call them Ehlers-Danlos syndrome. So the various forms of Ehlers-Danlos syndrome, or EDS, are caused by abnormalities in the synthesis and metabolism of collagen, which is a component of the extracellular matrix. As I stated, there's over 25 genes that occur. 15 of the 24 human chromosomes have one of these genes. Elastin and other structural proteins are woven into the microfibrillar array that provide the basic meshwork for the connective tissue. So, Ehlers-Danlos classic form type 1 is inherited as dominant. It occurs in about 1 in 10,000 individuals, and it's associated with changes in the collagen 5A1, 5A2, and they're located on chromosomes 9 and 2. Mutations of one of these two genes is identified in approximately 50 to 90% of patients that fulfill the clinical criteria for Ehlers-Danlos syndrome. So the skin is velvety. It's very stretchy. It almost feels like you're kneading dough. Easy bruising and poor wound healing. Often these children, when they're little, need to wear chin cups and things over their head because every time they fall, their skin breaks open. And then when it's repaired, it doesn't hold together. In fact, when they're suturing it, they usually have to do it in 2 layers. One of the things that we use in determining flexibility is something called the Beighton score. And the Beighton score is, we look at the hand and the fingers. Is there hyperextension at the elbows and the knees? And can they bend over and touch their floor with their palms on the ground, and obviously their knees straight. And this is a 9. So 1, 2, 3, 4, 5, 6, 7, 8, 9. So skin has a soft, velvety characteristic. It's atrophic, hyperpigmented. This is the typical picture of a knee of a patient with Ehlers-Danlos syndrome. This is something called the Gorlin sign, that you can take your tongue and touch your nose with it. Sounds disgusting. Anyway, vascular form, neonates can present with congenital hip dislocation or club feet. During childhood, they're at risk of inguinal hernias, joint subluxations, pneumothorax, and tendon and muscle ruptures. Facial features include a thin upper lip and small earlobes, easy bruising, mild hypermobility of small joints, but not significant hypermobility of the large joints. And there's a significant risk of uterine rupture during pregnancy of 5.2%. This is the most severe form of Ehlers-Danlos. Again, complications include repeated arterial ruptures, commonly involving the iliac, splenic, renal, and aortic, which can result in massive hematomas or death, rupture of intestinal viscera, again, thin, transparent skin, and significant risks of pregnancy, including vascular rupture, uterine rupture, and also tearing of the perineal tissue. So, a 3-year-old male has just suffered his 3rd fracture. He tripped over a coffee table. His father had 15 fractures during childhood, but has not had a fracture in 10 years. On exam, he has joint hypermobility and blue sclera. What is the most likely diagnosis? Marfan syndrome, Ehlers-Danlos classic form, osteogenesis imperfecta, Loeys-Dietz, or Ehlers-Danlos vascular form. And the correct answer is actually C. This is wrong. So I will fix it. And this concludes this lecture.